Hello and welcome to this short introduction to NHS Pharmacy First for surgery reception teams. We will cover what it's all about and how it provides you with new referral options. My name is Gareth McCaig from Community Pharmacy Leicestershire and Rutland, and I'm delighted to be leading this training webinar and sharing some of the fantastic features and benefits that Pharmacy First can bring to your practice and to the patients that you care for. We will look at what NHS Pharmacy First involves and the symptoms and conditions that can be referred. I will also outline how it can provide practices with extra referral options, which could divert perhaps one in every 5 or 6 GP appointment requests that you receive, and how this will ease time pressures on your GPs and on stressed out reception staff. So, what precisely is NHS Pharmacy First? Well, it's an expanded and rebranded version of the old CPCS service, the Community Pharmacy Consultation Service, which has been around since 2019. The patient care experience remains the same, namely a same-day consultation with their nominated community pharmacist. Notice an important characteristic of the old CPCS service was that the referable minor ailments were all treatable with over-the-counter or OTC medicines. And OTC medicines limited the extent of the care pathways and treatment options that pharmacists could offer. Whereas now, within the new Pharmacy First service, 7 of those treatment pathways have been extended thanks to PGD's patient group directions, allowing pharmacists to go further and to treat with prescription-only medicines under strict protocols. This slide lists the 70 or so minor ailment conditions that practices can refer into pharmacies. Also highlighted in the colourful blocks are those 7 extended care pathways, including sinusitis, impetigo, shingles, infected insect bites, and so on. Note the strict age restrictions which restrict pharmacy supply of the prescription treatment options. For example, it is okay to supply amoxicillin to a 17-year-old with acute otitis media, but it is unlawful to supply it to an 18-year-old under the patient group directions. In fact, the PGD would oblige pharmacists to refer back that 18-year-old to the surgery, where receptionists might feel confused if they were unaware of the age restrictions. But for me, the most significant message on this slide is to notice that these 7 extended care conditions represent only a few of the 70 or so conditions that receptionists can refer into NHS Pharmacy First. Yet these 7 conditions seem to be the focus of NHS public communications, which is sometimes giving a wrongful impression that they are replacing that long list of CPCS conditions. Simply what is different is just the extra treatment options available to the pharmacist. There are no real differences as far as reception referral processes are concerned. Receptionists can still refer these conditions as minor ailments, and you can see the corresponding symptoms highlighted in yellow. Most reception teams are familiar with this referral guide listing the 72 green symptoms. We have now highlighted the symptoms indicating the 7 conditions where pharmacists can offer prescription treatments. So it is probably easier for surgery reception teams to just continue using this highlighted referral guide with its simple symptom terminology and just leave it to the pharmacist to decide if that sore throat or earache is infected or not, and if a prescription product might be required. It's the pharmacist's job to decide, so reception teams shouldn't have to worry. Let's just quickly remind ourselves on how to use the referral guide, and let's use insect bites and stings to illustrate. Say a patient presents with a wasp sting and their arm has already swollen. This is a green referral symptom. It looks a bit weepy and it may be infected, but that's not a red flag, so carry on with the conversation. Then the patient mentions some funny chest palpitations. You notice this is on the red do not refer side of the guide, so this patient needs to see a clinician in the surgery. Note the spots have been added just for your information to identify those simple symptoms where the pharmacist might offer antibiotics if necessary. Whereas this triage guide picks out those 7 conditions where a prescription treatment may be appropriate. Again, the referable symptoms are in the green boxes. In particular, I would point out that chest infection is not included in these clinical pharmacy first conditions. Perhaps maybe in the future, but at the moment, regular community pharmacists have not been trained to use stethoscopes to listen to chests, and they cannot supply antibiotics for chest infections. So please remember that referred patients with wheeze and shortness of breath will almost always be referred back to the surgery. Another little point, if you use this triage guide, please avoid mentioning the actual diagnostic terms in the white boxes because it influences patient expectations for antibiotics. I'm sure reception teams are well aware of how frustrating it is when patients think they can skip the clinician and just demand prescriptions for antibiotics. This screen illustrates the PharmRefer logo, which hopefully all System 1 reception teams will be familiar with. If not, just Google PharmRefer training video for a 4-minute illustration on how it works. And if you need some setup support, please contact Jazz Dinza at Leicester Health Informatics. I'll just pause for a moment whilst people note the contact details there. In practice, you would log into PharmRefer at the start of your shift and then minimize the screen, and you will then just see the PharmRefer tab at the top of your screen. You will be working in System 1 when normally seeing patients, having found their patient record when they first present or phone up. Then, if you consider that a referral to a pharmacy might be appropriate, simply right-click and copy the patient's NHS number before you click on the PharmRefer tab. This is the screen you will come to when you click on PharmRefer, and I would strongly recommend that reception teams hit the Skip Triage button and go straight to Minor Ailments mode. Triage mode is better suited to practice pharmacists or nurses who might wish to refer patients into pharmacy first. On this screen, simply select the PDS option and then paste the NHS number into the Search by NHS Number box. There should be no need for searching by date of birth and postcode. You have already done that back in the System 1 screen, and copy the NHS number, which auto-populates all of the patient details. Then you will come to this drop-down long list of minor ailments, which is basically the CPCS list of minor ailments. Simply click one of them and pick a pharmacy from another drop-down box and hit send. Done. Simple, quick and easy. No post-it memos required, no follow-up NHS emails to send, no records to keep, because PharmRefer does it all. It also provides proof that the duty of care responsibility for this patient episode has been passed over to the pharmacy, which is important from a governance perspective. It would also be helpful to free type in any information that might be helpful for the pharmacist to know. The red arrows on this slide also show the minor ailment options that you would choose if it looks like any of the clinical pathway conditions are arising. The others are highlighted here in yellow on the slide you saw earlier to remind you of those simple symptom options which are all listed in that drop-down minor ailments list that correspond with those 7 clinical conditions. And just leave it to the pharmacist to decide if that earache or sore throat is infected or not. Remember, the pharmacist can escalate it at their end from a minor ailment referral to a clinical condition. This slide shows one of the triage screens which are better suited to clinicians, this one illustrating the sort of clinical considerations that arise if you don't skip triage. Unfortunately, the PharmRefer system unhelpfully assumes you want to use the triage mode, which is why you need to skip out of it. Please be assured it is the pharmacist's responsibility to ask these triage type questions, which are included in their pharmacy protocols, and they can escalate a minor ailment to a clinical condition as necessary. So skip triage is the key message here. Moving on, a red flag is when something more serious may be going on, and again, it is the pharmacist's responsibility for spotting them when you refer your patient electronically. The electronic PharmRefer record with its date and time provides a very quick way of tracing back and showing that you did indeed transfer the responsibility over to the pharmacist. The pharmacy consultation protocols are designed to identify red flag issues because we know that patients don't always tell the truth to receptionists who are trying to help. So please be reassured that it is usually a sign of the protocols working when patients are occasionally referred back. I would encourage you to respond very positively to such patients, saying you are glad the pharmacist spotted whatever it was and that you will now try and get them an appointment squeezed in a bit sooner now rather than later. When referring a patient, it is helpful to understand the pathway you are sending them along. The aim is to stream patients to the most suitable clinician in the context of scarce GP appointments, and receptionists are especially aware of the availability of GP appointments on a day-to-day basis. Let me pause my presentation mode, if you like, and let me ask you a direct question. If you had a nasty sore throat or earache, would you prefer to be offered a doctor appointment in a week or 10 days' time, or a same-day consultation with a pharmacist? This, while knowing if you are referred back, you would be fast-tracked for one of those reserved urgent appointment slots. Which would you choose? So now, consider a patient contacting you. They are describing green symptoms that could be seen by a pharmacist. So you might helpfully suggest a same-day NHS consultation with a local pharmacist, whilst saying that the alternative is to wait for whatever the number of days might be until the next GP appointment. If the patient is happy, simply send the electronic referral message and mention that the pharmacist will now be aware and the patient will get an SMS reminder. The patient and the pharmacy should make contact within 4 to 6 hours to arrange a consultation. After the pharmacy consultation, the pharmacist will send an electronic report back to the surgery for input into the patient's medical record, including details of any medicines supplied. Sometimes the outcome is advice only, or possibly advice plus an over-the-counter medicine. This raises an important point. Reception teams are aware that doctors are advised not to prescribe OTC medicines like ibuprofen or paracetamols, so be mindful that the same guidance applies in this NHS Pharmacy First service. So, patients would be asked to pay for such OTC medicines. Whereas, if a prescription medicine is needed, then the normal NHS payment or exemption rules would apply. Sometimes the pharmacist may refer to another clinician, such as an optician, or if there is a red flag symptom, the pharmacist might escalate back to the doctor or possibly to A&E if it was deemed necessary. Having spoken about referral backs, I would share this wonderful data set of CPCS outcomes, which shows, for example, 80% of referrals for cough, cold and sore throat symptoms were resolved by the pharmacist. 75% of skin rash problems were sorted. 81% of diarrhea and constipation problems. 80% of minor eye problems, etc. Most people would agree that 8 out of 10 is a great score. But it improved to 9 out of 10 for the conditions where pharmacists can offer prescription treatments. So, if your reception team makes around 10 referrals a day, you should anticipate at least one referral back every day. So, don't be disappointed when they arise. And so, please assure your patients that a pharmacy consultation is most likely to resolve the problem and they can crack on and see the pharmacist same day. Receptionists often ask, why can't I just signpost patients to the pharmacy? There are several important reasons for electronic referrals over signposting. Number one, referred patients will be seen by a pharmacist in a private consultation room, whereas verbally signposted patients are most likely to be seen by a retail assistant in the retail area of the shop, perhaps after some queuing up, which is not what they will have been expecting. Number two concerns the transfer of the duty of care mentioned earlier, and this I would suggest is the most important reason. An electronic referral creates a digital track record verifying the duty of care has been transferred to the pharmacy, demonstrating that reception has appropriately responded to the patient inquiry. A third reason is that you are being seen to take some action. You are actually making an NHS referral and the patient gets an immediate SMS message. Otherwise, no action is seen to be taken, and patients will often say they feel fobbed off. Properly referred patients do not report feeling fobbed off. Another reason concerns DNAs or did not attends, which is potentially a risk if the patient initially agrees to being signposted and then they change their mind. What if they go straight home, the condition gets neglected and symptoms get worse? Whereas pharmacies will phone electronically referred patients to arrange a consultation, which serves to chase them up and helpfully reduces the risks associated with DNAs. A good management reason for electronic referrals is they can be easily measured and audited, whilst verbal signpostings cannot be. Finally, with electronic referrals, pharmacists can anticipate the patient rather than them just turning up. Otherwise, Sod's law dictates that patients will pitch up during a frantically busy time or when pharmacy staff are at lunch. The patient may have to wait, and so the consultation gets off to an unsatisfactory start for all involved, all adding to a very strong case for electronic referrals over signposting, whilst the key operational reason being it does not even add 30 seconds to the overall receptionist contact, whilst it will definitely save a 9-minute GP appointment. Some poster resources are also available to support implementation of pharmacy referrals from your surgery. These have been designed to inform patients that the NHS Pharmacy First service is a high quality, planned and considered NHS treatment pathway. So it is important that it is presented as such from the start of the referral process through to service delivery. I trust this was helpful. Please email service support for further information or visit our website if you wish to review this presentation again or for downloadable PDF copies of the referral guides. Good luck with your Pharmacy First services.